Hi, good afternoon. This is we will be discussing, welcome to our multimodality imaging conference. We'll be discussing aortic disease today. And two people are speaking. I'll be the first speaker. I'll be discussing how you assess aortic disease with CT and CMR. And then our second speaker will be Dr. Quiñones, who will round it off with echocardiography. So I hope this can be an interactive session. You guys have questions, please feel free to ask me. So here's the general outline of how we're going to proceed. We'll go over some basic anatomy of the aorta. We'll talk about different imaging techniques, their strengths and advantages. We'll learn a little bit, where you should be making measurements and how to make measurements of the aorta. We'll discuss a little bit about some reference values for dimensions. And then finally, we'll get into the different disease states of the aorta, which includes, of course, the acute aortic syndromes, aortic aneurysms, and some inflammatory disorders and some congenital abnormalities. So I think a pretty full course for today. So let's just discuss a little bit about the aorta here. The aorta is, as you know, is the largest artery in the body. It's really composed of 5 different segments. You have the aortic root as one part, then it's followed by the ascending aorta, followed by the aortic arch, followed by the descending thoracic aorta, which ends at level of the diaphragm, and then finally the abdominal aorta. It's composed, as you know, the arterial wall, which is important for a future portion of this lecture, is composed of 3 layers, the intima, the media, and the adventitia. And then finally, the aorta actually has a very interesting function. It's called, and you may have heard of this, it's called the wind kessel function. And basically, in systole, when the heart contracts, the aorta expands and due to its elasticity and is able to store this energy. So in diastole, it functions as a second pump to actually propel blood forward throughout the body. This is called the wind kessel function. We're now getting into the different techniques. Dr. Quiñones will really be showing you, echocardiography in great detail. I'm just going to give you some one-liners. And the things to remember are, transthoracic can be a very good technique at looking at the aortic root and some portion of the ascending aorta. If you do suprasternal images, you really can see the arch and some of its branch vessels well. However, as you know, with echocardiography, you're really dependent on your acoustic windows and whether the patient can produce good images. So it's really can be it may be compromised in some patients. And of course, you're really unable to see the descending thoracic aorta, but you can then again see the abdominal aorta, and it can be a very good screening test for aneurysms for that pathology. Transesophageal echocardiography really is very superior to looking at the aortic root and very proximal segment of the aortic ascending aorta. However, unfortunately, because the left bronchus comes between the esophagus and the the ascending aorta, you really are blinded to a very good portion of the aorta. From the ascending aorta to the arch. And then, of course, as you know, you can see the descending thoracic aorta well with TEE. Now, so that brings us to some of the more advanced imaging techniques. This includes CT and MRI. And these techniques have, as you know, a lot of advantages and really are the go-to test when it comes to knowing and visualizing the aorta and following people serially for aortic conditions. And why is that? Number one, they provide full coverage. You can evaluate the entire aorta, including all its small branches, and actually a lot of the, in one study, we have very high spatial resolution, excellent image quality with both techniques. And as you're assessing the vasculature, you can also assess extravascular structures, which can also give you insight into different disease states. When we look specifically at cardiac CT, what are its strengths? As you know, the CAT scans are now available everywhere, so widespread availability. It's an extremely accurate test, and I'll show you some data on that. You know, the speed of acquisition, we can acquire images, you know, a head-to-toe scan in almost less than 5-6 seconds. So the speed of acquisition is very good, very fast. It can be very important for patients who are critically ill or those who are claustrophobic. And then the speed of how quickly you can do 2D and 3D post-processing. We've already mentioned its spatial resolution is its strength. And then at the same time, you not only can you visualize the vessel, but then you can also visualize the effect of the vasculature to solid viscera there in this imaging field. It can be compatible with ferromagnetic materials in comparison to cardiac MRI, and then you know it's a great tool if you have to also study the coronaries. What are the limitations? Of course, you are delivering radiation to your patients. We've done a lot of effort in order to decrease radiation doses, and that's for another talk, but we have a lot of protocols in place to help limit radiation dose to our patients. You are receiving iodinated contrast. Some patients can be allergic to it. There is some concern of contrast-induced nephropathy in a certain patient population. And of course, a lot of that you try your best to preempt. And then calcium can be a friend and it can also be a foe. And sometimes with CT, it can be, it can cause a blooming artifact which can obscure readings obscure the lumen and interfere with the interpretation of stenosis assessment. What about cardiac MRI? This technique is also, and as I will show you in some upcoming data, is very accurate. And some particular unique strengths that CMR has that we've mentioned in other talks. As you know, it's a fantastic tool for tissue characterization. You'll see, I'll show you some slides of how it can help you with aortitis. It's a great tool as a functional analysis. If you have patients who have bicuspid aortic valves, to visualize the morphology, to assess the stenosis, to assess the regurgitation. In patients who have dissection flaps, to be able to see the mobility of the flap and the consequences of that. So as you know, it's a very quantitative tool. And then we have the ability to do dynamic MRA, and what I specifically mean by that is to do time-resolved MRA, where you can actually see the perfusion of blood, and that can be very important, may be very important in cases, for example, of aortic dissection. We can use CMR in ways completely without contrast, and of course, if your patient is allergic, this can be a definite test. As you know, gadolinium does have a limitation in those patients who have GFRs less than 30, and here at our institution, we've been using ferromoxetol in those patients. We'll talk a little bit about 4D flow, which is possible now with CMR, and that this is a completely radiation-free technique. And if you have a young patient who needs a lot of serial imaging, this would be a great test. What are the disadvantages? Obviously, this is a technique that's not available in every institution, so access becomes an issue. This is a much longer study than a 10-second CT. We're talking on the order of an hour. Metal is not a friend of CMR, so something to keep in mind. There is gadolinium contrast and the issues around it with nephrogenic systemic fibrosis. And then finally, this is a technique where you're completely blind to calcium, and if that's important, you're not going to be able to see it. So now we'll move on to really how do we go, once you know the anatomy, you know your techniques, and here we'll be talking about CT and MR, what do the guidelines recommend of how you should be making measurements and where you should be making these measurements? So this is from the 2010 guidelines for thoracic aortic disease. And you can see the first thing that they mention is that the aortic diameter should be taken at reproducible anatomical landmarks. And this was very nicely spelled out. You should be taking measurements at the widest part of the aortic sinus, followed by the sinotubular junction, then again at the mid-ascending aorta. You make another measurement at the proximal aortic arch right before the right innominate. This is then done by a measurement in the mid-arch between the left common carotid and the subclavian artery. The sixth measurement is done 2 centimeters distal to the left subclavian, and that's at the isthmus of the aorta. This is followed then by a mid-descending aorta, number 7, and finally another distal descending aortic measurement right at before the aorta at the level of the diaphragm. And then you have your abdominal aortic measurements. So these are where, if you have a patient who comes in through the lab for monitoring of the aorta, one of the important points I want to stress is we should know where we need to make our measurements. The second thing these guidelines then recommend is that with using CT and MRI, it's important to make measurements perpendicular to the long axis of blood flow. And they specifically state that they should be done using the external diameter. Now, there is controversy of that. We'll talk about this in a little bit, and then I'll give you my take on the entire situation. So here is an example of that. If you'll take a look, we're trying to measure the mid-ascending aorta. And what you'll notice is using the long axis views, we create a double oblique where you create a true short axis of the mid-ascending aorta. And as the guidelines here would recommend is you would try to do external border to external border measurements. Now, and the reason the thoracic guidelines recommended that was because that if you are in the setting, if you do have a patient who has aortic wall inflammation, aortic dissection, or if they have intra-aortic thrombus or atheroma, you take that into account. So that was their reasoning and justification. More to come on this. Where it can be very, very important, why do we need to do this double oblique method? And this is a great example of that. So here is a very tortuous descending thoracic aorta. If you were just to make a measurement of the axial slice, which is done here in figure C, the bottom left, you can see you would get a measurement of 11.8 centimeters because this aorta is actively turning in that direction. However, if you were truly to do a measurement using the double oblique where you're perpendicular to the long axis of blood flow and create a real nice short axis of this vessel, you can see, yes, this aorta is still enlarged, but the marked difference in the values from 7.8 to 11.8 centimeters. This is also a good example of why the thoracic guidelines mention making external diameter measurements, because you can see the amount of mural thrombus in this bottom image, and you would be taking into account that thickness of the wall. There have been, software, aids to help you make your measurements. These are called our center line tools. Basically, all the newest software can track the center line of the vessel and pretty much help you to create a measurement of a true short axis of your vessel. So this can be used. Now, is it 100% foolproof? No, but it can be a tool that can help you at least decrease the variability in your measurements. What do the thoracic aortic guidelines mention for the aortic root? And here that's highlighted here. Here all they said was that the aortic root measurements should be made at the widest diameter, typically at the mid-sinus level. Now, this was followed in 2015 by another update, a multimodality imaging update of the aorta, this time from the ASE and the European Association of Cardiovascular Imaging. And this was also endorsed by SCCT and SCMR. And as we learned from this documentation, well, there's many different ways to measure at the widest portion of the sinuses. Do we do sinus to commissure, also known as sinus to trigone, or do we do sinus to sinus? And MRI studies and other CT studies have shown that if you do sinus to sinus measurements, these are 2 millimeters larger than your sinus to commissure measurements. So how should you do that? So in this guideline, they were very clear on how they felt they should be done. They felt there's an advantage of doing the sinus-to-sinus measurement, and the real reason was because of the ease of detecting the cusph margins, both in this with CT and MRI in transverse planes. The close agreement that you are able to obtain with echocardiography. I'll go into some of the data with that. And then when it comes with bicuspid valves, this is an easy measurement you can obtain. And they specifically write, what you can do is best is to average the 3 sinus-to-sinus measurements in end diastole in the sinus of Valsalva plane. And if you do have a case where the sinuses are asymmetric, it may be preferable to report them individually. So this is what these guidelines recommended. And these guidelines went ahead, and Dr. Q will talk, I'm sure, about this, is that of the 3 different techniques to measure the aorta, whether it's inner edge to inner edge, outer edge to outer edge, or leading edge to leading edge, this guidelines recommended the leading edge to leading edge technique for measurements as seen in figure B, which is highlighted. And the reason was, and they clearly state, that this leading edge to leading edge method links to a large body of historical and, more important, prognostic data that influence decision making. So what about CT and MRI, right? With CT and MRI, these are 2 examples. What diameter, how should I do it? Should I do it by the internal diameters, which would be the inner edge to the inner edge? Or should I do the external diameters, which would be the outer edge to outer edge? Question mark. Well, both guidelines, here, again, the 2015 update and then the 2014 ESC guidelines on the diagnosis of aorta, both of them clearly state, unfortunately, that for when it comes to CT and MRI, societal guidelines are currently unavailable. Consequently, uniformity in measurement methods is completely lacking. Both guidelines mention this in clear text. And there's a lot of reason for this. There's a lot of confusion as to how to make the measurement, agreement in the literature between different techniques. Should you do this in end systole? Should you do this in end diastole? A lot of uncertainty with the advanced imaging techniques. So I'm not going to solve this today, but what I will do is I'll tell you what we know, and then I'll tell you what I think maybe we should consider as an institution. So what we do know is that studies have nicely shown that if you compare transthoracic leading edge to leading edge diameters, and here specifically looking at the non-coronary to the right coronary, which is a very common measurement that's done, that measurement best correlates with the inner edge to inner edge, or the luminal interface to the luminal interface, whatever you want to call it, diameter by CT and MRI. So you kind of don't try to, with CT and MRI, you don't try to take the wall, you just go to where the lumen is. So those echo measurements, leading edge to leading edge, match very, very nicely with our inner edge technique with CT and MR. This has been shown for the aortic root. This has been shown for the ascending aorta. So I think that's one very, very nice thing to take away, that at least when it comes to the root and ascending aorta, we have ways, 2 techniques that can corroborate with each other. The leading edge to leading edge technique by echo, the inner edge to inner edge technique by CT and MRI. The 2015 guidelines also made it a very big point, which was often not mentioned in the previous guidelines, is that you really should try to gate your images. There are many reasons for this. One is you can see without gating, there's tremendous pulsation artifact in the ascending aorta and root. What this can cause is tremendous amounts of artifact in that area. So not only can you make a mistake of calling a dissection when there's not one, but it can also, if you do not gate, you're going to have very imprecision in your measurements. So gating can be a very good way to decrease the variability in your measurements and increase your precision. So must do gating. Studies have also shown us that it is important to know whether your measurements are in systole and in diastole. This is one study that's been published that went ahead in completely normal patients and evaluated the aorta in different locations, both at end-systole and in diastole. And you can clearly see here that end-systolic measurements are greater. So you will have a difference in measurements whether you acquired in systole or diastole. So this is just to show you some of the data that's out there, and then, the conclusions are, what should you do, right? So here are my conclusions for Dr. Shah to ponder. And this is, one thing is for sure, is that we should have some standardized protocol for an institution, so at least we decrease some of the variability that we are seeing. You should be gating your images. You try to achieve slice thicknesses less than 1 millimeter. That way you'll have more isotropic voxels to be able to do the double oblique. I think we should do diastolic measurements. We should do the double oblique short axis method as is recommended by the societies. I feel since we have very good correlation with echocardiography, that we should be measuring internal diameters for the aortic root and ascending aorta. This will corroborate with the leading edge to leading edge measurements that are obtained by echocardiography that is linked to a lot of prognostic data, which I have not shown, but has been mentioned in the guidelines. However, where atherosclerosis is present, which is usually the descending aorta and the abdominal aorta, I feel we should do external diameters there, because that's when you can take account to the mural thrombus and all those other things. And really, that's what the surgeon is going to measure when he puts that caliber around the vessel. And so I feel that maybe for the descending thoracic aorta and abdominal aorta, we should do external diameters, which are outer edge to outer edge. Most important, I think we got to start mentioning our reports, how you do these measurements. And in cases where there is a question, there is no excuse not to pull up the old study, to make your measurement yourself. Because it's at the exact same location, between the two studies by one person, and then really comment on that as to whether there's a meaningful change or not. So what I recommend. Now, when it comes to what is normal, this is not an easy answer either. There are a lot of texts out there. This is one of them that show you what should be normal measurements. I don't think you need to commit anything to memory. What you need to know is that, number one, this is also very variable and also is influenced by a lot of different factors. Aortic size can be dependent on a patient's age. It increases as we grow older. Gender, males have bigger aortas than females. BMI, as our BMIs increase, aortic sizes increase. Blood pressure, hypertensive patients have bigger aortas than non-hypertensives. And then we've talked about a little bit about location and measurement methodology. So there are a lot of variables, and it's hard to describe what's normal. This is just an example of a patient as you age. You can see all the different aortic measurements get bigger as we age. Here's just looking at between male and females. You can see males in general have slightly bigger aortas at all the different locations compared to females. This is just data Dr. Q will be showing you with echocardiography. They've shown exactly the same things, that aortic sizes vary by BSA and sex. There are publications out there by CT that can index your aorta to your BSA. And in this study, low-risk patients were those who had less than 2.75 centimeters per BSA, and high-risk patients were those who had greater than 4.25 centimeters per BSA. Now, what's interesting about all of this is that this is not foolproof either, that unfortunately, even if you index to BSA, we know there's problems in indexing to BSA. People are unfortunately a lot bigger today than they were necessarily in the past, and that, you may underestimate a patient's risk, and so this doesn't correlate very tightly with prognostic data as well. So that's one thing. I will show you some new techniques that people are doing. They're indexing area to height, and that shows a little bit more interesting correlations. But this doesn't necessarily also correlate with prognosis. It gives you an idea. This is a graph I just showed you that your largest measurements should be at the root or the ascending aorta, and then the aorta gradually tapers down from there. So I will come back to that issue of sizes when I get to another portion of my talk. So we'll come back to that. So now I'm going to kind of transition into the different disease states. You know, aortic diseases, there's a lot of different diseases that we can visualize. There's inflammatory disorders, there's congenital abnormalities, there's traumatic injuries, there's aortic aneurysms. There's the acute aortic syndromes, which is the one we all get worried about, and these are dissections, intramural hematomas, and penetrating aortic ulcers. Now, I think it's important for you to know that, you know, there are inflammatory diseases out there that affect the aorta: Takayasu's, giant cell, Behçet's, ankylosing spondylitis. It's important to know these diseases exist because you will come across one day a patient who has abnormalities that you find on a CT gram that could be the CT test, that could be your first link to one of these diseases. And this is just a case from the literature of a patient with Takotsubu's who shows a lot of the very classic involvements of the large and medium-sized arteries, where you have diffuse narrowing of the aorta, you know, occlusion of some of the branch vessels, et cetera, et cetera. So it's important to note that connective tissue diseases, rheumatic diseases can involve the aorta, and you will see this in your practice. There's a lot of interest, what do you call it, Dr. Basil? No, we want to look up here. What do you call it? Interest with CMR can all, you know, with gadolinium contrast, both non-contrast and with contrast techniques. This was a study that was published by our own Dr. Al-Sabik, who showed very nicely findings of aortitis demonstrated by cardiac MRI. Here on a T1 image, you can see a very bright, intense T1 intensity on your T1 weighted images. And then when you look at your LGE, you can see hyperenhancement of the ascending aorta. T2, oh, sorry. Yeah, correction, T2, that's a typo there on the screen. And then the good thing was, in this particular case, the patient actually went to the operating room, had sufficient degree of aortic regurg. They biopsied the ascending aorta, and they found giant cells of the ascending aorta. So this was a very nice pickup by our lab, and really, you know, hopefully meant some benefit for the patient. There's a lot of interest now using PET with FDG. Dr. Mullah, he's there on Twitter. He's, what do you call it? You can see here a nice example of the aorta lining up with the macrophages are taking up FDG and lighting up, and there's going to be a lot of, I think, clinical data coming out of years, as here's a patient with rheumatoid and how you can track inflammation with cardiac PET. Let's move on to congenital diseases of the aorta. This is a nice case of coarctation. As you know, coarctation, you have a discrete narrowing of the aorta. CT MRI can be very, you know, can give you exquisite pictures. You'll often see a lot of collateral vessels trying to, you know, get blood to the, if it's a significant enough coarct, to the lower extremity. And what do you call it? As you know, that CT and MR are class 1 recommendations by the congenital heart disease guidelines. One of the things I wanted to bring up, that actually phase contrast CMR can be helpful in determining severity of a coarct. As you know, we can't tell pressure with CMR, but what we can do is we can tell flow. And if you measure the flow prior to the coarct region and measure the flow distal to the coarct region, if there's any step up in flow, that is a sign of a significant coarct. And the reason is you have a step up in the descending aorta, which normally should not be the case, because you have a lot of collateral vessels that are now dumping into the descending thoracic aorta. So an interesting use of phase contrast CMR in the evaluation of coarctation. Believe it or not, I didn't think, we're not a trauma hospital, I didn't think we'd see a traumatic injury. Now, I didn't see it acutely, but I have seen a patient who was involved in a car accident and really presented many years after his car accident with a chronic pathology of an acute aortic injury. and it was nice to have seen that. But you should know that blunt injuries of the aorta can be common. They're commonly seen with car accidents or patients who fall from extreme heights. The isthmus of the aorta is the most susceptible, and the reason for that is it's really a transition point between a fixed and a mobile aorta. And you can have a lot of very serious findings there, such as intimal flaps, extravasation of contrast, pseudoaneurysms, and the like. So it's just something to be aware of. Let's move on to thoracic aneurysms. Here's a compendium of different images showing you aneurysms in the ascending, descending thoracic aorta, as well as the abdominal aorta. Most important point I want to tell you is that if you have disease above the ligamentum, this in general is due to medial degeneration. And medial degeneration diseases that are associated with medial degeneration are those such as genetic diseases, such as Marfan's, Loeys-Dietz, Turner's, Ehlers-Danlos, and then, of course, bicuspid aortic valves. So diseases above the ligamentum are very different from diseases below the ligamentum. Diseases above the ligamentum are medial degeneration, generally genetic in origin. Diseases below the ligamentarium are a disease of atherosclerosis. Very important point, I think, take-home message. So this is an important thing to know. And, and for the, whenever we see ascending aortic aneurysms, it's important to know a little bit about different imaging features of the more common genetic syndromes associated with thoracic aortic aneurysms. So here is an example of a patient with Marfan syndrome. Y'all have probably all seen one. These patients have pectus excavatum, and then they'll have a pear-shaped, aortic root and ascending aorta. They can often MRI can be very helpful because they'll often have aortic insufficiency, and you can quantitate that as well. So, just an example of a typical board question of an aorta, and ask you what's the diagnosis here. Bicuspid aortic valves also have an associated aortopathy. Bicuspid valves, as you know, are 1 to 2% of the population, but 20% will have a concurrent ascending aortic aneurysm. So it's important to screen these patients, and that is recommended by the guidelines. We'll be hearing, I hope in the future, Dr. Yang is here with us, and he's trying to evaluate, a lot of these patients who have bicuspid valves, we know they have altered flow dynamics in the ascending aorta, and people are using 4D flow as a way to determine whether you can predict which aortas then go on to abnormally remodel and cause an aortopathy. So I think we'll see a lot of data coming out on this in the future. This is also, 4D flow is also being used to be looked at aortic dissections. So here's where I get back to what do you need to know about sizing? Well, the sizing is, when do we do something about it, So if you look at the simple ascending aortic aneurysm, the size for intervention is 5.5 centimeters, or if they're growing very fast at more than 0.5 centimeters per year, or if the patient is symptomatic. If you have a bicuspid aortic valve, the guidelines were updated. First, they still recommend at 5.5 centimeters, but then they were given as a class 1 indication, but they were updated in 2016 where they gave a 2A indication that if you have a bicuspid valve and you're more than 50 millimeters or 5 centimeters, and you have one other risk factor, and that risk factor includes a family history of ascending aortic dissection, a very fast growth rate, and the Europeans also included in that coarctation that you can consider surgery at 5.0. So that's what's to remember about bicuspid valves. And then Marfan's and all the other genetic conditions that have medial degeneration, you can so we were at 5.5, we went to 5 for bicuspids, you go down to 4.5. So that's kind of how I remember it for the genetic conditions. What about the descending thoracic aorta and the abdominal aorta? Guess what? Your life has been made easy, 5.5 centimeters. So if I can stress anything, 5.5 centimeters for the aorta. All right. There's a lot of interest in other things that can predict better than dissections and whether something is pathologically enlarged. And one of the things that are coming out, since BSA may not be helpful, how about indexing to height? So there's one paper here looking at 1,000 bicuspid valves, and what they did was they took a cross-sectional area of the sinus of Valsalva and ascending aorta and indexed it to the height. And what they found that if you have a ratio greater than 10 centimeters per meter, this was much superior predictor of type A dissection. So something novel, next time you see a bicuspid, try measuring the area, indexing it to the height, and maybe reporting that out to the surgeon. Every now and then, if you had a very bad aneurysm, I hope I never see this in my lifetime, but you should probably know what a rupture looks like. Finally, for the aortic syndromes, to give Dr. Q some time as well, these are three entities: aortic dissection, penetrating aortic ulcers, intramural hematomas. These are life-threatening with a high risk of morbidity and mortality. They all have very common presenting symptoms, most common being acute tearing chest pain radiating to the back, most common risk factor being hypertension. Of these three pathologies, aortic dissection is the most common at 72% and IMH at 28%. You should know we classified them using the DeBakey, which involves the ascending aorta, there's the DeBakey classification, and then there's the Stanford classification. Stanford's a little bit easier. If it involves the ascending aorta, it's A. If it involves the descending aorta, it's B. So that's kind of simplified. I'll just skip this. Why it's important to grade, because if you are a Stanford A, this is surgery in order to prevent life-threatening complication. If you're a Stanford B, you're uncomplicated, you can be treated medically, whereas if it's complicated now, you can use TVAR. Dissection, this is an actual tear in the intima where blood seeps into the intima. This is a very high mortality rate where if you have an ascending aortic dissection, there's a mortality at 1 to 2% per hour. So very, very, it needs to be diagnosed quickly. Hypertension is the most common cause. You can see CT and MRI, outstanding diagnostic accuracy for making the diagnosis. Here are common examples of what it looks like by CT and MRI. You'll appreciate a double-barreled lumen. You'll usually find an entry and exit site tear, and more than likely the aorta will be dilated. You should know that this disease process affects multiple organs, and why it's important to know that is because then you can start looking for complications of dissection. Here, demonstrating pericardial effusion, a hemothorax, and a coronary dissection. Once you get into the head and neck vessels, you can cause strokes by dissection of the arch vessels, mesenteric ischemia with infarction of the SMA or celiac, and then compromise of the bilateral renals. Believe it or not, a non-contrast CT can be very helpful if you see displacement of calcium into the middle of the aorta. The only thing that can do this is an intimal flap that's sitting in the middle. And here's a great example of that. This patient had displacement of calcium into the middle of the aorta. When contrast was given, you can now very nicely appreciate a thrombosed false lumen. Contrast this to a very nice, just a simple aneurysm with mural thrombus where you see calcium on the outer wall and not in the middle of the artery. CMR, very powerful technique. We have many different ways to look at morphology, both without contrast and with contrast. Bright blood, and black blood techniques to demonstrate morphology. CMRs, so that can be strengths, though of course we know as the dynamic functional imaging. Here's an example of a very mobile dissection flap, and then we can actually use phase contrast CMR to demonstrate flow both in the true and false lumen and to actually measure it. CMR can also, because of its dynamic nature, you can actually find patients who have dynamic obstructions of these intimal flaps that in certain portions of the cardiac cycle, they can actually occlude either the mesenteric or renal arteries, compromising perfusion to those arteries. You can actually visualize that, as in this case demonstrated here. And then CMR has the ability, of course, just like CT, to be able to visualize the entire aorta. But one of the one of the things, one technique that it has without any radiation is this time-resolved MRI, where you can actually follow the contrast of blood through the aorta. And this can be very helpful because you can look at flow patterns in the true and false lumens. So it's important to know that when you're giving measurements, about the aorta, there are a lot of things the surgeon would like to know that's mentioned here. Intramural hematoma is really a rupture of the vasa vasorum and bleeding into the media of the artery. Good thing to remember, 1/3 can resolve, and we'll go over that. CT, believe it or not, non-contrast technique is the best for it because it'll show a hyper enhancement of usually around 40 to 70 Hounsfield units, and it'll be a concentric lesion along the outer wall. When you give contrast, it can be a little bit harder to see, so where you have to have your guard up. But the key facets that you should remember are you'll have no enhancement of that area after IV contrast, there'll be no intimal tear, and you will not see spiraling. So these are very important points. CMR also, this was published by Dr. Shah, showing you that using these same principles, that if you have an absence of an intimal tear, absence of contrast uptake into that aortic wall, both acute on the first run and then in equilibrium, this can be a very good marker of an IMH. And in this study, they very nicely showed a case where a patient had, and this is the top image, where you have an IMH, and then this patient was treated medically, and you have complete resolution on serial follow-up imaging. Penetrating aortic ulcers are really when you have a lot of atherosclerosis, and this protrudes into the media, erodes into the media, causing a hematoma. This can be really bad and can develop into future complications of dissection or rupture. Here are some examples by CT, and MRI will look exactly the same. Basically, they're wide-mouthed focal outpouchings, mushroom-like. Here's just another example of that. Here's an example of a patient who had a POW, and then that was followed, and you can see it became a saccular aneurysm. So I'll let Dr. Q tell us the next portion of it.
Thank you, Faisal. That was a beautiful talk. How can I connect here now? Let's see. Here we go. Which would be faster? Looks like this might be faster. All right. Now, how do I get this? We have to get you out.
Is there a button to press to switch over? Where is that?
Here. So you have to change which one you're using.
Laptop connected. VAG. I'm using this here.
Is your computer made to project?
Yeah. This normally takes not zero time at all.
What are we trying to do?
From the laptop. I'm connected this way. I can connect any way you want because I use both.
That's not going up.
I can use this one if you have
They
it.
tried pressing.
Do you have an HDMI?
Yeah. You have an HDMI?
No. Yeah, there is an HDMI.
Yeah, let's use the HDMI. Here. I have it.
See the video goes over there.
Beautiful talk. And no question that gated CT. It's very important to make that important. Yeah, gated CT in assessment of the aorta overall is king. However, we cannot ignore echo for two reasons. One is frequently it's the first imaging that is done in a patient, and then an aneurysm is detected. So it's the first imaging technique that frequently detects a silent aneurysm. That's number one. Number two, because in the absence of gated CT and CMR, if you go and practice in a place that do not have those, TEE is superior to conventional CT by a radiologist without gating. We did it for many years, and I can show you a lot of cases where the radiologist missed and we picked it up by TEE. So in that circumstance, the TEE is the king. If all you have available is a regular CT without gating done by radiology. That I feel very strongly about. Now, let's talk a little bit about imaging views, because that's the important thing. We do this every day, and the aortic root hardly ever is missed. It's always seen very nicely in a parasternal view. However, the ascending aorta is more tricky because it requires one of two techniques. Either you slide the transducer higher up to get more of that ascending view, and that works in 80% of the times. But occasionally, you may have to turn the patient on the right side and do a right parasternal view to bring the ascending aorta better. So the ascending aorta doesn't quite hit you in the face when you're doing a conventional parasternal view. However, you can, with techniques, you can see it in over 90% of the times. Very important point because that allows us to diagnose aneurysms that are silent. The arch is usually easy from the suprasternal view, and we see that basically the arch with the proximal part of the ascending, we don't see the distal ascending usually. And the important point is the descending thoracic aorta is not that hard either. If you do a short axis view, which we all do, doing an echo, but then you rotate the transducer in between short axis and long axis, you become parallel to the spine. And once you're parallel to the spine, you can pick up the descending aorta in about 75, 80% of times. If you work a little bit at it, you can see it quite often. Of course, the abdominal aorta, we see it from the subcostal view. So a lot of the aorta can be seen with a transthoracic view. And with TE, of course, we do a lot of it. So again, at about 130, 140, depending on each patient, we see this LV outflow view that we use every day to look at the aortic valve and the junction of aortic and mitral, and the aortic root frequently comes in very nicely. If you do X-plane, you can do the X-plane and get also a nice short axis of the aortic root and do the measurements as needed. However, for the ascending aorta, it's better to be around 100. You foreshorten the aortic root, but you bring a lot more of the ascending aorta. So somewhere between 88, 90, 100 is a better angle to seeing as much as we can of the ascending aorta. There's always a blind spot where the trachea is because air and ultrasound do not like each other. Descending is very easy. We do it every time when we come out and we scan the whole aorta, and then we rotate and see the arch. So again, you see a lot of the arch, but there's a little portion here, which is that blind spot where neither the esophageal or this view here can see. So that is one of the weaknesses of TE, that if you have a very localized lesion in that area of the blind spot, you could miss it. Faisal covered this beautifully, and this is the same quote that he gave, where there's no uniform method of agreement between all the techniques. However, best agreement with CT and CMR when they do inner edge to inner edge is by echo using leading edge to leading edge. And that's an important point, particularly because A, patients don't like to be in the magnet often, they are claustrophobic, and B, you don't want to do irradiations every year if you can hold it. So if you can get a good agreement between echo and CT, you could use your ultrasound periodically for following and then use CT wisely as you need it to confirm. You saw this slide earlier. that the aorta is not standing still, it's moving, its sizes are changing between children, adolescents, young adults, older adults, hypertension, body size. And instead of memorizing all this, you basically put these nomograms in the lab so that you can review them. An important point, because every single day we're reading echoes in the echo lab. Notice that an elderly person with a big body size can have an ascending upper limit of even 4.3, 4.4. So, when we get those aortas that are looking in that 4.2, 4.3 range, before you say mild enlargement, take a peek. Male, yes or no? Hypertensive, yes or no? Body size, big or not? Because then you may want to change that statement to upper limit rather than enlargement. And those statements that we send to the clinician has importance to them. I mean, they do say mild enlargement, they may be thinking we have to repeat it every 2-3 years or whatever, So be careful when you make this statement, because it may be just a simple normal upper limit for that particular patient. And that's basically the take-home message. Nice example. This fellow is a patient of mine, 55, 48 millimeters by CMR and CT. Happen to have them for two different reasons. As you can see, there is aortic valve disease. And both agreed on that. And, we have a beautiful agreement with the echo. So now I can use echo serially and then decide on CT when to use it, depending if my echo shows progression of disease. This is a nice aneurysm that was just basically picked up. And the measurements also had agreement with CT. I'm not going to dwell too much on this because Faisal picked it up very nicely. These are the acute aortic syndrome, the last one rarely seen here at Houston Methodist, but obviously quite often seen at acute trauma hospitals. And these are all conditions where gated CT is superb. You saw the images. It's hard to beat that. And CMR is excellent if you have time to get into a magnet and if you have the equipment and the technology and the expertise. But if you don't have any of that, TE can be extremely helpful. Again, the classification, the DeBakey classification here, Stanford classification over here. Same for dissection as for acute aortic syndromes. And TEE gives you truly a beautiful, beautiful look at a dissection in 99% of the times. This is a type, this is a type 1, and this is a type 2 where only we can see it ending right here at the arch. Both will be called type A's because both are ascending aorta. So what is it that our eyes are seeing? They're seeing a structure that does not belong there, and it's jumping, and it's moving, and it has kind of a movement of its own. And that last phrase is the most important thing. So here we have a type 3. You can see the arch is nice and clean, and then we see the flap beginning right there. For TEE, the most common cause of a false negative, if you have expertise, is basically a tiny dissection or ulcer or hematoma right in that blind spot. That really is the most thing. Same thing for a type 2. So the blind spot is usually the place that we have the most problems. Same thing for a small intramural hematoma. False positive, on the other hand, are 90+% most frequently caused by reverberations. Occasionally, a thrombus in an aneurysm might make us look twice and think, gee, maybe could this be a false lumen? But most of the time, it's a reverberation that creates problems. So you see that there? Dissection, yes or no, right? So a very important paper that was published by a Spanish group in Barcelona back in '96, they did a beautiful job showing that reverberations move parallel with the walls of the aorta. So you look at this and you go, oh, wow, that's a dissection? I mean, first look, it's very scary, very concerned. Actually, it's interesting because this was a TEE done in a woman with acute chest pain, concerned with dissection, and she happened to be one of the leaders in the, there is a lay public association for dissections, for Marfans, and she was one of the leaders in that that association. Well, good news for her. You can see very nicely that this was parallel and she just had chest pain for other reasons. But first look was kind of scary. What about that one? That doesn't look so prominent either. Yet, we take another look and we see that there, and then you see that flap right there. So actually, first look was not too impressive. You keep looking, this was a true dissection. All right? So what I'm showing you is examples to bring 2 points. TEE resolution is excellent. A little bit of expertise gain, which hopefully you all will when you come out of our fellowship, should allow you to truly, if you need to use TEE, be able to make a diagnosis quite often. A little trick, I've shown this always, because once you're done with your TEE, if it's a type 1, if it's a type A, take the probe, clean it, put a little acoustic glue on it, and stick it in the neck. Actually, it gives you a beautiful resolution of the carotid. And you might see the flap has got into the carotid. Little trick, put it in your hands, sneak it in here, and roll over the neck, okay? Takes less than a minute. The other thing, TEE can be very helpful with AI. See, that's one area where, again, if you have AI, the resolution of the TEE shows you very nicely if the flap is, in fact, prolapsing into the LV outflow and the AI is caused by the dissection, and therefore the aortic valve can be left untouched when they repair. So that's one thing that TEE can be extremely helpful. All right. So this is an interesting case because Faisal talked about treatment of type 3s, and usually it's medical, right? So what makes us intervene? 2 things. A, if the false lumen ruptures, not a good thing, or if it looks like impending rupture. B, if you serially follow the patient and there is expansion, but that's not an acute decision. That is a long-term chronic decision. So all of these people are followed. Some of them start expanding, developing a big aorta, and they will need something to be done. And of course, CMR can play a very important role here because we can look at dynamic flow patterns in the false lumen that may predict future expansion, and that's will be a topic for a talk almost on its own because it's a wonderful area of development. But acutely, you would only be intervening if you are concerned with rupture. So here's a case of a patient that actually, if I can show you, I don't know, let's see. Yeah, here we go. So here you have, this is the false lumen. And as we are moving around, now we have an area of rupture. So the false lumen is here, and then it ruptured, and luckily, a clot formed, and the patient survived enough time to be diagnosed. So those are areas now, obviously, a CT would show it, a CMR would show it. This happened to be a situation where we were able to see it. Intramural hematomas, just as Faisal showed you, this crescent look appearance of a very thickened aorta wall because of the thrombus there that we can see by CT is exactly what we see by echo. So if you were doing a TE, you would be seeing the same thing. Now, the problem is, if it's a small localized hematoma, particularly in that blind spot, it could be sometime missed. But the appearance is very similar to the appearance by CT. This is an interesting patient also that we had coming with severe back pain. Initially, they thought it was a penetrating ulcer. When that was quickly excluded, they were concerned with dissection. They did an aorta, and this is look at how much calcium there. And this is exactly what Faisal showed you, a penetrating ulcer. And these are just different types of those ulcers as published. But again, a diagnosis that is not too difficult. Usually there's a lot of calcium, severe atherosclerosis, and then there's a rupture point, and then you have this entrance, and by TE you see a lot of clot around. I'm sure that by CT you see it often also. And then this is the last part that I think TE is extremely helpful, the debris. Because I think that one advantage of TE is the high time resolution. So yeah, we can measure the size of the plaques. We can look at no plaques, grade 1s, which is mild, grade 2s, grade 3s, atheromas. We can look at localized atheromas. With the X-plane, you can put the image where you wanted to see the atheroma. Here's one where you find it there, you put it right there, and then you can see very nicely a raised atheroma. Sometimes if they are very close to the arch, they can be TIA etiology for strokes on TIAs. But most importantly, we can see these very complex atheromas where there is fragments that are mobile. As we joke, unidentified mobile objects. And these things really, nothing beats TEE in terms of the ability to see these rapid type of mobile objects, which were shown in a study done in this institution many years ago to be clots. So most of the time when these things go to surgery, here's one, a 3D picture of it, they're thrombus. And this was a beautiful study done by Gondanasa, and I heard he's almost getting close to retirement. This is when he was a fellow. He must have made a lot of money if he's thinking of retiring now. When he was a fellow, and we had Dr. Crawford here, and we took several of these people to surgery, and every single time it was a clot that we found at surgery. Problem is we don't have a good treatment for this. There are a few randomized trials. This was one of the trials that are still being quoted. To make a long story short, warfarin doesn't do much. So right now, it's usually dual antiplatelet therapy. It's been a very frustrating entity, and people do have strokes from these things. And the question is, if you have one that looks as bad as the one I just showed you, in somebody that has had perhaps more than one recurring stroke, should one consider stenting it? Now that you can actually go in and maybe pluck that out? I would strongly consider if one of my patients, I haven't had one yet, but I tell you something we should consider. If you have somebody with recurring strokes coming from an area that has a localized debris, should we just put a stent there and push that thing out? Or surgery, but stent is more appealing than having to go in and do an operation. So I hope this helps you a little bit because, you guys are going to finish your fellowship, you're going to go in practice, you don't know where you're going to land. And if you have access to what we have here, because we're blessed with everything here, certainly CT will be what you'll be using the most of the time. CMR, you'll be using it quite often, I would say, in dissections, particularly follow-up to look at the dynamic behavior. And echocardiography quite often will be the very first thing that will come in your eye when you're doing a routine echo and you pick up asymptomatic patients with aneurysm. So I think it's good to have a good knowledge of all three. With that, thank you very much. Any time for questions? All questions directed to Dr. Nabi. Perfectly clear to everybody? You guys know what to do? All right, great.